Hello, everyone, and welcome back to the Insight Room, where we understand the mind one insight at a time. My name is Stephen Feldman, and I'm a licensed mental health counselor with experience completing pre-surgical mental health evaluation for gender-affirming medical procedures. In part one of this series, we discussed gender dysphoria, DSM-5-TR terminology, biological sex, gender identity, gender expression, and several common misconceptions that often create confusion around this topic. Today, we are shifting our focus from understanding the diagnosis to understanding the mental health evaluation itself. Throughout this video, I'll pause periodically and explain why I ask certain questions. My hope is that by understanding the reasoning behind the evaluation, the process will become less mysterious and more transparent, whether you're someone considering gender affirming care yourself, a family member, a student, or another healthcare professional. As with part one, this video is intended for educational purposes only. Clinical recommendations should always be individualized and made in consultation with qualified healthcare professionals who are familiar with your specific circumstances. With that in mind, let's begin by answering an important question. Why do gender-affirming mental health evaluations exist in the first place? It's a fair question and one that many people ask before they ever meet with a mental health professional. For some individuals, the evaluation may initially feel like just another appointment, another form to complete, or another hurdle before surgery. In reality, a comprehensive mental health evaluation serves as a much broader purpose. Gender affirming surgeries are amongst the most significant medical procedures that a person can undergo. Many are partially or completely irreversible, and recovery can be physically and emotionally demanding, and successful outcomes depend on much more than technical skill of the surgeon. A comprehensive evaluation helps determine whether someone understands the procedure they're considering, has realistic expectations about what surgery can and cannot accomplish, has the capacity to provide informed consent, and has appropriate psychological, medical, and practical supports in place throughout the process. Having another diagnosis does not automatically prevent someone from receiving gender affirming care. In fact, many individuals successfully receive gender affirming treatment while also managing other psychiatric or medical conditions. The question is usually not whether another diagnosis exists. The question is, do those conditions impact life, and are those conditions adequately understood, appropriately treated, and reasonably stable, and whether the individual can safely participate in informed decision making and post-operative recovery. These evaluations also help identify practical issues that can significantly influence recovery. For example, does the individual understand what recovery will involve? Will they have reliable transportation? Who will help them after surgery? Do they have appropriate housing? Will they be able to attend follow-up appointments? Do they understand the potential complications and how to respond if something goes not as expected? Rather than serving as a barrier, a high-quality evaluation should improve communication between the patient, the mental health clinician, the primary care provider, the endocrinologist, and the surgeon. Ultimately, everyone involved shares the same objective to help patients make informed decisions, receive individualized care, prepare for recovery, and achieve the best long-term outcomes. To understand why modern gender-affirming mental health evaluations look the way they do today, it helps to understand a little bit of the history. In 1979, what was then known as Harry Benjamin International Gender Dysphoria Association published the first standards of care. These early guidelines were developed during a time where very little research existed. Relatively few surgeons performed gender affirming procedures, and access to care was extremely limited. The patients were expected to complete what's commonly referred to as the real life experience or real life test. This generally involved living publicly in their experienced gender for an extended period before becoming eligible for certain medical or surgical interventions. Psychotherapy was often mandatory, and individuals frequently underwent extensive psychiatric evaluations before progressing through treatment. Historically, patients were often expected to present in a very specific narrative. Many felt pressure to describe themselves as having always been, quote unquote, trapped in the wrong body, to recall childhood behaviors that fit traditional gender stereotypes, and to demonstrate a consistent desire to be the opposite sex from early age. The standards of care of that era also reflected social and medical understanding of the time. Sex, gender identity, gender expression, and sexual orientation were often conflated into a single concept. In some settings, heterosexual orientation after transition was considered part of the evaluation process. Example, a transgender male to female having sexual preference to males. And individuals who did not fit into that traditional expectation of masculinity or femininity sometimes encountered additional struggles through the evaluation processes. Along the way, the organization itself also changed its name to the World Professional Association for Transgender Health, or WPATH. Change reflected a broader shift away from having every aspect of gender diversity through a purely pathological lens and more towards recognizing the diversity of gender experience while still providing evidence-based healthcare for individuals experiencing clinically significant gender dysphoria. Rather than asking, does this person fit one specific narrative, today's clinicians are much more likely to ask questions such as, how has gender dysphoria affected this individual's life? What treatments have they already tried? What are they hoping that will improve? What risks need to be considered? What supports do they have available? And how can we help this particular individual achieve the safest and best possible outcome? A comprehensive evaluation should educate, identify strengths, address potential concerns, coordinate care with other healthcare professionals, and help patients prepare for both surgery and recovery. The emphasis on informed decision making and individualized care rather than simply approving or denying treatment. It is also important to recognize that WPATH publishes clinical guidelines, not laws. Requirements may differ depending on surgeon, healthcare system, insurance company, informed consent model, and even the country or the state where the care is being performed. For example, some surgeons continue to request one or more letters of support for most procedures, while others follow different protocols. Likewise, some hormone treatments are initiated through informed consent models without requiring a mental health letter, whereas other settings may have different expectations. A patient may work with a primary care provider to coordinate their general medical conditions, an endocrinologist to manage their hormone therapy, a mental health professional to address the gender dysphoria and prepare for treatment, and one or more surgeons who perform gender affirming procedures. Each member of the healthcare team contributes different expertise, and communication among providers helps improve continuity of care and surgical outcomes. All right, so far we've discussed why these evaluations exist and how the standards of care are involved with them and how they've evolved over time. Now I'd like to take you inside a comprehensive gender affirming mental health evaluation and explain what I actually do during one of these assessments. I want to emphasize that this is my approach as a licensed mental health counselor. Every clinician has their own style, every surgeon has their own preferences, and every healthcare system has its own documentation and requirements. Likewise, evaluations should always be individualized to the person sitting in front of them. What I'm going to show you here is not simply a checklist. It's the framework I use to understand the whole person and to provide the surgeon with information that meaningfully informs patient care. Every evaluation begins before I ask a single clinical question. The first thing I establish is who I am, my credentials, my role in the patient's care. I identify myself as a licensed mental health counselor, document my license information, my practice information, and my experience conducting gender affirming mental health evaluations. If applicable, I also document that I meet my state's requirements to independently complete these evaluations without supervision. My responsibility is to provide an individualized psychological assessment, identify strengths, identify potential concerns, educate the patient when appropriate, and communicate clinically relevant information to the rest of the treatment team. This isn't simply a simple written letter. It's about contributing meaningful information that helps everyone involved provide safe, individualized, and evidence-informed care. Once that's established, I begin gathering demographic and background information. Does the patient primarily speak English? Do they require an interpreter? Do they have hearing impairments? Are there learning difficulties, autism spectrum disorder, reading comprehension difficulties, anything that could influence informed consent or post-operative education? Next, I want to understand exactly what procedures the patient is considering. This is much more important than simply asking, so what surgeries do you want? Instead, I document each requested procedure individually. That may include procedures such as breast augmentation, chest reconstruction, mastectomy, orchiectomy, hysterectomy, oophorectomy, vaginoplasty, vulvoplasty, vaginectomy, metoidoplasty, phalloplasty, facial gender affirming surgery, tracheal shave, or any other type of procedure. Every procedure has different goals, different risks, different recovery timelines, different functional outcomes, different post-operative requirements. Someone pursuing chest reconstruction has very different recovery process than someone preparing for vaginoplasty or phalloplasty. Likewise, someone requesting facial gender affirming surgery may have concerns that are very different from someone requesting genital surgery. I also ask whether procedures are planned all at once or over multiple stages. Many individuals undergo gender affirming care over several years, and understanding that timeline helps me understand both their expectations and their long term treatment goals. Each procedure deserves its own discussion regarding expectations, recovery, benefits, risks, alternatives, and the specific ways that surgery is expected to improve that individual's life. Once I understand what procedure someone is considering, the next step is understanding their history. I'm trying to understand this person's experience. I'll ask questions like, when did you first begin noticing gender dysphoria? Has it been relatively constant or has it changed over time? Were there periods when it became more intense or less noticeable? What have you already done to help reduce your dysphoria? Some people have socially transitioned. Some people have changed their name or their pronouns. Some have started hormone therapy. Some haven't done any of these things. If someone has already started gender affirming hormone treatment, I'll ask how long they've been on those hormones, who's managing those medications, how consistently they've taken them, and perhaps most importantly, how they described their response. What improved? What didn't? Did hormones reduce dysphoria? Were there emotional changes? Did new concerns emerge? I will also ask one of my favorite questions: why now? Why is this the point in your life where you're pursuing surgery? Why not 5 years ago, 2 years ago, 3 years ago? Why not wait another 5 years, 2 years, 1 year? There isn't a correct answer. Understanding the timing often tells me a great deal about the person's decision making process and whether this represents a thoughtful, well considered decision or a reaction to something more immediate. I'm not trying to determine whether someone's history is trans enough. I'm trying to understand persistence, consistency, insight, and how gender dysphoria has actually affected this individual's life over time. Understanding the story is often far more informative than simply checking diagnostic boxes. Once I understand someone's history, I want to understand something equally important. How do they believe surgery will actually improve their life? Notice I didn't say, how will surgery change your body? I asked about functioning. For every procedure someone is requesting, I ask them to describe, in their own words, how they will benefit from it and how it will improve their daily life. Will it reduce dysphoria? Will it improve relationships, increase confidence, reduce anxiety, improve intimacy, help them feel more comfortable at work, more confident in their life, allow them to participate in activities they've been avoiding? In general, does it improve their overall quality of life? This helps determine whether expectations are realistic and whether the proposed treatment aligns with the person's goals. Another area that many people don't expect me to explore is education. I ask, how have you educated yourself about the procedures you're considering? People answer this in many different ways. Some have already talked with surgeons. Some have spoke with their primary care provider or endocrinologist. Some have read patient education materials. Some have watched medical documentaries. Some have talked with other transgender individuals who have undergone surgeries. Some have reviewed scientific literature, and some have primarily relied on internet searches or social media. It's also about understanding recovery, complications, postoperative care, fertility implications when applicable, realistic aesthetic outcomes, possible revisions, and the emotional adjustment that can occur after surgery. Because informed consent requires accurate information, I'm not testing someone's intelligence. I'm trying to determine whether their expectations are based on reliable medical information rather than assumptions, misinformation, or unrealistic portrayals in social media. Next comes one of the most misunderstood parts of the evaluation. Many people assume I ask, do you have depression? Do you have anxiety? Instead, I'm asking something much broader. How might surgery, anesthesia, recovery, pain, stress, and major life changes affect this individual's mental health? We review any current or past diagnoses, such as depression, anxiety disorders, OCD, PTSD, bipolar, schizophrenia, autism spectrum, personality, ADHD, eating disorders, or substance use disorders. Having one of these diagnoses does not automatically prevent someone from receiving gender affirming care. In fact, many individuals successfully undergo surgery while managing one or more of these health conditions. The important questions are the symptoms reasonably stable? Is treatment working? Does the individual have insight into their condition? If symptoms worsen during recovery, what's the plan? Who will they contact? What supports are already in place? Pain, anesthesia, temporary dependence on others, disrupted sleep, and limited activity can all temporarily affect someone's mental health. After reviewing someone's mental health history, the next step is reviewing medications. This includes prescription medications for depression, anxiety, ADHD, bipolar, psychosis, sleep, and other psychiatric conditions. I also ask about supplements, herb products such as St. John's wort, medical cannabis, and other substances that could influence surgery, anesthesia, or recovery. Next, we really get into the substance use. This includes alcohol, nicotine, cannabis, and any other substances, both current and past. I also ask about recovery history if someone has struggled with substance use in the past. This is one of the most important and often overlooked parts of the entire evaluation. I spend a significant amount of time discussing what happens after surgery. Where will the patient recover? Will they remain in their own home? Will they stay with the family? Will they stay with friends? Do they have access to clean private bathroom? Are there stairs that could make recovery much more difficult? Who will drive them home? Who will help them during the first several days after surgery? How long will that support be realistically available? Can they prepare meals? Can they obtain medications? Can they attend follow-up appointments on their own? Will they have enough time away from work? Can they manage bills and other responsibilities while recovering? One of the final parts of the evaluation involves discussing expectations. Together, we discuss questions such as, do you have realistic expectations regarding the appearance of the surgical outcome? How much do you expect surgery to reduce your gender dysphoria? What improvements do you expect in your daily functioning? What limitations might still apply to you? Have you considered the possibility of complications? Do you understand the level of support that you're going to need during recovery process? Have we discussed fertility implications when applicable? Have we discussed potential changes in sexual functioning? Do you understand the risks, benefits, and alternatives? Finally, I complete my professional recommendations and documentation. I attest that the evaluation reflects my independent clinical judgment, documents my credentials and license, indicate my willingness to participate in care coordination as needed, and provide individualized recommendations based on the assessment rather than using generic templates. Now that you've seen what a comprehensive evaluation can actually look like and many of the questions that are likely in it, I'd like to finish by addressing some of the most common misconceptions that I hear from patients from time to time. Misconception one, the therapist decides whether I'm transgender. No, mental health professionals do not determine someone's gender identity. I can't tell whether they're transgender, cisgender, non-binary, or anything else. What I can do is assess whether someone meets diagnostic criteria for gender dysphoria when appropriate, evaluate how that distress affects their functioning, assess readiness for treatment, identify strengths and potential concerns, and help coordinate care with the rest of their treatment team. Misconception number two, the evaluation is just paperwork. If you watched this video, you probably realized that's far from the truth. A well-done evaluation examines mental health, medical history, treatment goals, informed consent, support systems, recovery planning, education, medication, substance use, and many other factors. Misconception number three, I only need one or two appointments. This is often not true. The number of appointments depends on many factors, including the complexity of the case, the patient's history, the procedure being considered, and the amount of collateral information available, and the clinician's professional judgment as well. In my own practice, I generally encourage ongoing therapy throughout the process, not because it's always required, but because major medical procedures often bring significant emotional, psychological, and practical adjustments before surgery, during recovery, and afterward. I'm not looking for a particular story. I'm not looking for specific answers. I'm not expecting someone to say that they've known since they were 5 years old. I'm not expecting someone to describe themselves as being trapped in the wrong body. And I'm certainly don't expect every person's experience to look the same. The more honest someone is about their experiences, uncertainties, goals, and concerns, the more useful the evaluation becomes. The actual clinical work is usually thoughtful, it's collaborative, it's individualized. Instead of asking broad philosophical questions, we ask practical clinical questions. In the final part of this series, we'll move beyond the evaluation itself and discuss gender-affirming hormone therapy, surgical procedures, recovery, post-operative care, and what people should realistically expect before and after treatment. I'll see you for part 3 here in the Insight Room, where we understand the mind one insight at a time.